Just before you start, sir, this presentation is very important and very timely, looking at the importance of the topic. Today, like we all know from the flyer, that today is the World Heart Day, and Nigerian Medical Association Jigawa State Chapter, under the able leadership of Dr. Abdulbasid Yusuf, decided to use the occasion and celebrate this day, and also create awareness and also update the knowledge of our colleagues on the use of basic ECG in the management of cardiovascular diseases. We know that cardiovascular diseases are the major or the leading cause of mortality worldwide, especially in sub-Saharan Africa, that is the developing countries where there is lack of good healthcare or quality healthcare, in which you have high burden of the major risk factor of cardiovascular disease, which is hypertension. Statistics have shown that over 20 million people die of heart disease every year. And we are all aware of the sudden death we have been recording in our communities, and even other complications from cardiovascular diseases. So this is the reason why we chose this topic, and we chose Dr. Sabiu Hamza to present, because we know he will do justice to this topic. He's an excellent scholar, a specialist in the cardiovascular field, working with Federal University Dutse and Rasheed Shekoni Federal University Teaching Hospital. Without wasting much time, Dr. Sabiu, I think you can proceed.
All right. Yeah, good morning, everyone. Good morning, Dr. Husseini, for the introduction. I am Dr. Sabiu Mohammed Hamza. Today, I'm going to talk on the role of ECG in the management of cardiovascular diseases. First of all, I want to start by thanking the leadership of NMA for organizing, Jigawa State Chapter, for organizing this very important topic. As we are all aware, today, 29th September, is the day in which we celebrate, World Heart Federation celebrates World Hypertension, World Heart Day. Because every 29th of September, we celebrate World Heart Day. But the theme of this year's presentation, celebration is Use Your Heart for Action. And based on that, we felt there is need for us to talk on the role of ECG in the management of cardiovascular diseases, especially in Jigawa State. So the campaign is aimed at raising awareness about the cardiovascular disease and encourage individuals to take care for their heart. And the theme for this year also emphasizes on the importance of heart health, and then to also urge the leaders or the policy makers to take action in addressing this global health issue. Because as Dr. Husseini has already said, that cardiovascular diseases are the leading cause of morbidity and mortality worldwide. So for this reason, knowing how to interpret ECG is key to understanding how to identify cardiovascular diseases and manage them effectively. I don't have any disclosure or any conflict of interest, and by way of introduction, the ECG is the most widely used imaging tool in the diagnosis and in management of cardiovascular diseases. It has now become a well-established diagnostic instrument. It has become a well-established diagnostic instrument in the field of primary care medicine. And we are all aware that despite the overwhelming evidence of increasing cardiovascular burden in Nigeria, availability and accessibility of this basic tool in our facilities in all states of the Federation is a serious challenge, including Jigawa State. In addition, Basic interpretation of ECG recording is also a challenge even among healthcare workers. So for this reason, the importance of this presentation is to highlight the importance of ECG in the diagnosis and management of cardiovascular disease in our environment, and to discuss the basics of ECG interpretation, and to stimulate discussion on the need to increase access of ECG machines in all our general hospitals in the state. And this is with a view to improving early diagnosis and management of cardiovascular diseases. Okay, let me say that I am not here to make us cardiologist or to make us expert in ECG, but ECG, I'm here to give the basics of how to interpret ECG, to understand and interpret ECG. ECG is a procedure that graphically depicts the electrical activity of the heart on a piece of paper. It's easy to perform and a non-invasive tool. It can detect cardiac rhythms or rhythm abnormality, the pattern with which the ECG, the pattern of ECG, that is the rhythm. It can also detect conduction abnormalities, rate and rhythm abnormalities, structural abnormalities, electrolyte disturbances of electrolyte, and other. It can also as well be able to identify problems of other organs, especially lungs and the brain. Without proper diagnosis of these conditions, many of the ECG, with which the ECG is an important tool, many of the cardiovascular diseases cannot be able to be identified. So the procedure entails a patient lying. Okay.
Sorry, Dr. Sabiu, the slides are not
Hello?
moving. The slides are not
Hello?
moving. The slides are not moving.
The slides are not
they are
moving.
static. Yes. Dr. Papola.
What of now?
Not yet. Okay, okay. They are moving now. We are on which slide?
Can you see the slides now?
Yes, it has moved to indication now. We are on indication.
I don't know what's happening. Can you see the slides now?
Yes.
Can you see the slides?
Yes, yes. So
you can see them now,
moving.
right?
Yes, we are seeing it.
Okay. Okay, so the procedure uses entails a person lying on a bed, on a couch, with a technician applying leads on the chest and limbs of the patients, and the limbs, proper applications of the limbs of the chest leads and limb leads have a significant role in proper ECG tracing and proper diagnosis of cardiovascular diseases. So if you are not able to place the leads in a proper way, you can't be able to, one cannot be able to, the interpreter cannot be able to fully diagnose the patient, and you can make mistakes in the diagnosis of the patient. So you have to apply the leads. The limb leads are applied on the limbs. There are 4 leads that are applied on the right hand, right leg, right hand, right leg, left hand, and left leg. And you also apply the leads on the chest wall. And in the chest wall, the leads are applied on the 4th and 5th intercostal spaces. In the 4th intercostal spaces, lead 1, V1, is applied in the 4th intercostal space to the right of the sternum. V2 is inserted at the 2nd intercostal space to the, 4th intercostal space to the right of the left of the sternum. V4, you first apply V4, which is at the mid-clavicular line. V3 is in between V2 and V4. V5 is located applied on the 5th intercostal space anterior axillary line, while V6 is applied at mid axillary line. So what are the indications for the ECG? There are many indications for doing the ECG, but commonly the ECG can be used as a baseline for medical checkup. If you are going to conduct to do a medical checkup of a patient, ECG is among the investigations that you do to the patient, because it helps in diagnosing cardiovascular diseases. So all patients, it's recommended that all patients with chest pain, palpitations, dizziness, syncope, seizure, cyanosis, or any form of poisoning, including snake poisoning, any form of poisoning, chemical poisoning, ECG is also indicated. ECG also is indicated for symptoms associated with heart disease, like if the patient comes and or like, the doctor find that the patient is having symptom of tachycardia or bradycardia, or signs of tachycardia or bradycardia, or he diagnosed hypertension, hypotension, heart failure, cardiomyopathy, and ACS, ECG is indicated in that individual. All diabetic patients, irrespective of the presence or absence of chest pain, should have an ECG. For suspected primary pulmonary embolism, also, if you suspect patient to have pulmonary embolism, pulmonary hypertension, or COPD, there is need for you to do and to request for ECG, electrocardiography. Patient with stroke or seizures also, ECG is indicated in them. Patient with suspected electrolyte abnormality, you need to do an ECG. Here, I need to tell our listeners that ECG is not a difficult investigations to interpret, because many people are afraid of interpreting the ECG because probably of the fact that they don't follow the format of interpretation, or they don't know the basics of cardiac anatomy and physiology. So here, I'm here to tell you that ECG is easy to interpret, and if you follow the format of the preamble, checking the age, gender, BMI of the patient, checking the calibration, the rhythm of the patient, the rate at which the heart is beating, the axis of the heart, the waves and intervals and segment, and make the overall summary, you will be able to fully interpret ECG. So what are the basics? As you're all aware that heart is an organ in the body that that mainly is responsible for pumping and pumping blood to the rest part of the body for tissue supply of oxygen and glucose, which is responsible for energy generation, that energy generation for whatever activity that one will do in life. So it has 4 chambers. It has upper chambers and lower chambers. Okay, the upper chambers are the receiving chambers. Okay, the left receive blood from the lungs, while the right receive blood from the system, and the blood goes to the heart, where it's pumped to the rest part of the body for glucose supply and oxygen supply. Then, if you are able to, and it has a pericardium coverings around it. So any abnormality affecting the coverings, if there is fluid accumulation, or there is abnormality in the myocardium, or abnormality in the chamber enlargement, the ECG can be able to detect that. So also, in addition, it can also detect any abnormality that affects the blood supply to the heart itself through a vessel called a coronary arteries. So within the heart, you can also have conducting tissues. The electrical activity is generated by the SA node. SA node is the specialized tissues in the junction between the spherovenous cava and the right ventricle, where the electrical activity is generated. And when it's generated, it's spread across the heart. Okay, it will first stimulate all the cells in the atria, and subsequently it gets transmitted to the ventricles through the AV node. So any abnormality in the generation, conduction, those electrical activities can result in problems that you see in electrical on the ECG. So as you are all aware, every cell has a heart is an organ. An organ is a constellation of many tissues to bring about an organ, and many cells coming together will form the tissue. So each cell in the heart has the potential to generate. The S node is the generator of the electrical activity, but every other cells in the heart can have the potential to generate electricity if the sinoatrial node fails. So the generation of the electrical activity is through the depolarization that happens in the membrane of the cell. Assuming that this is a cell, and within the cell you have sarcolemma, which is the membrane. So once there is a generation by the sinoatrial node, the electrical impulse will be generated through the depolarization, change in potential. It will change the potential. At the resting stage, the cell is electronegative. So if there is this generation of electrical activity, that generation of electricity would be transmitted across the membrane, thereby stimulating the membrane to change its polarity. And this depolarization will cause opening of calcium channel, which will lead to the calcium to get into the cell and cause a mechanical activity. As you are all aware that the heart is a contractile muscle. So this, as you can see, that this electrical activity always precedes mechanical activity. So there has to be this change in the depolarization. So if you hear depolarization or repolarization, they are the changes that are happening in the membrane of the cell, and then contraction will subsequently happen, which is the mechanical activity or relaxation. So relaxation and contraction are the mechanical activity, while depolarization and repolarization, they are the electrical activity. So always the electrical activity will come before the mechanical activity would happen. So at the resting stage, if you stimulate the cell will first depolarize, and this depolarization is caused by influx of sodium and some extent some potassium of calcium, especially for the sinoatrial node. And this depolarization would.
Sorry, I think the presenter has frozen, network issues, but hopefully he will be back soon. Network, Dr. Popular, network has shifted him out.
Realize that we have no option than to wait for him.
Yes, yes.
Let's exercise some patience.
Yes, yes. So while we are waiting for him, let me talk about some of the risk factors that of this cardiovascular disease. As primary medical care providers, that is first contact care, most of us, we see patients in our general hospitals. So they see us before we decide to refer them. So prevention at blood level is very, very important because they'll come with their hypertension at an uncomplicated stage. So we need to identify other risk factors of cardiovascular diseases in them and try to manage those risk factors so that we delay onset of complications, sometimes even reverse some of the pathology that has already taken place. Most of these risk factors can either be genetics, that is somebody inheriting a gene that probably one of his parents or both of them are hypertensive, while some can be environmental, both physical environment and even social environment. In the physical environment in form of air pollution and some other things that can exacerbate or cause cardiovascular diseases, while in the social environment and even you know, how we deal with stress, how we manage, you know, our own stress and day-to-day activity, whether we are taking enough rest, whether we are doing exercises and the kind of food that we eat. Then that's going to lifestyle as a form of group of risk factors that can also be managed. talking about weight management, we have to try to counsel both ourselves and our patients and educate ourselves and our patients on proper weight management, not to tilt ourselves into overweight or obesity, which are also known risk factors for cardiovascular diseases. Exercise is very important, and hence the theme of this year's celebration as use heart for action. We use heart, no heart. So we should advocate to our patients to exercise, especially if the blood pressure is well controlled, and we ensure that there is no underlying cardiac condition that may be exacerbated by the exercise. That's through the use of our ECG to make sure that they are fit for the exercise. And the exercise is usually moderate intensity exercise, where you can ask somebody to exercise for at least 30 minutes every day for 5 days, for at least 5 days in a week. That's 150 minutes in a week is found to be adequate to drive all the cardiovascular benefits that that particular person will be able to drive. It can take a form of brisk walking for 30 minutes every day. Cycling is also another option that can be taken. So if you are doing that, it means you are active and you are putting the heart in action, and that translates to a lot of benefits in the cardiovascular aspects. Then the diet, of course, there are certain diets that are not heart friendly. Either they contain a lot of cholesterol or a lot of other triglycerides that are found to be also, or to elevate risk factor for complications or even institute cardiac conditions. So those diets, we should try to avoid them and eat more healthy diets, such as more of fruits, vegetables, and high fiber diets, and avoid more of these junk foods that are readily available, especially those that contain a lot of cholesterol, such as them shawarmas, some other snacks, meat pie, all those food that you see readily available. Then smoking is one of the important risk factors for cardiovascular disease. So once we identify that our patient smokes cigarettes, we should make all effort to see that we try to inform them to either cease smoking or drastically reduce it if the cessation is not practicable at a go. So, but then the hallmark is continuous follow-up for those patients to ensure that we help them stop the cigarette smoking. That is the ultimate goal. Of course, alcohol, although not a major problem here, but alcohol in excess also is a risk factor for cardiovascular disease. So we should be seen to educate our patients and ourselves on how to moderate on these risk factors that we mentioned. Very, very important. It's not just about seeing the patient with hypertension and then giving antihypertensive for him to go. That is only the pharmacological aspect of the management. But what we are emphasizing, what we want to emphasize is the lifestyle aspect as well. We should take our time and counsel them and try to inform them of the possible other risk factors that they have that will add to their hypertension. Hypertension, of course, is the major risk factor, but overall, other risk factors that we mentioned can also contribute in accelerating the disease condition, cardiovascular disease condition of the patient. So they need to be mindful of these risk factors. And I tell you, our patients, they listen to us a lot. You see, I'm sure you have had many occasions where people will be telling you, my doctor said I should do that, my doctor said I should take that, my doctor said I should not eat that. So they listen to us a lot. And it's for us to take our time, although we have busy schedule, mostly our clinics are packed, but we should take a few minutes to go through these risk factors and try to identify them, and try to also counsel and educate patients on how to avoid them. This is our role at the primary medical care level, where we try to do primary prevention. Once we do this, the burden of the disease is going to, of course, over time, improve from millions of mortality and morbidity that we are recording every year to lesser values of those figures. Because if you look at the major burden, it's mostly in the developing countries. The mortality we're talking about, almost 75% is in the sub-Saharan Africa, while the developed world, where they have a robust healthcare system, they suffer less of those mortalities due to very quality care at the primary care level, where they try to do primary prevention. Our presenter is not yet back. Okay.
Yes, sir. I think the presenter is still not yet back. Maybe he's
Yes.
experiencing network problem.
Yes. Let me try to call him.
Okay.
Well, I know he's doing all his best to see that he's back.
Yeah, exactly.
I just called him, and he's trying to get back.
Yeah, definitely. It is the network. Because today when I woke up, I couldn't use my MTL line to browse. Hello. Yeah, welcome back, sir.
Yeah,
We can hear
back.
you. You have to unmute. Yeah, he's back.
Okay.
Unmute, sir.
Where is he?
I think he is still muted.
Okay, let me see. Okay, he's muted. Let me call him. I don't know whether he's using his phone. Let me call him to tell him that he should unmute.
Hello?
I hope he...
Hello?
Yes, we can hear you now. Have you unmuted yourself?
We can hear you, sir.
Dr. Sabiu? Yes, can you, unmute yourself. We can't hear you. Unmute yourself, the speaker.
Maybe he's having some terrible network. Hello, can you hear me?
Yes, we can hear you.
We can hear you, sir.
He's experiencing network issues.
It's a network issue that is the problem. I just called him now. He said he's coming. And where he is, the network is so bad. Because some of us have stable network now.
And Wallah, we're enjoying his presentation. He has organized his slides.
Yes.
Before he comes back, we can just start discussing one or two things.
Yes, you can go ahead, Mr. Chairman.
All right. So maybe I will start talking about the waves of the ECG before he comes back. I don't know. I think he stopped at the indications for me.
Yes, he stopped at the placing the leads. So we
Okay.
passed that one. Mhm.
All right. So the waves of the ECG, actually we have the P wave, we have the QRS complex, we have the T wave. Usually the P wave represents the atrial contraction, which is an upward deflection. Then between the P wave and the QRS complex, we have the PR interval. Then the QRS complex represents the ventricular contraction. Usually the atrial contraction is not reflected on the ECG because it's buried within the QRS complex. Then the T wave represents ventricular repolarization. And the interval between the S and the T, the S wave and the T wave, usually is an isoelectric line. So we have the PR interval, we have the ST interval, which are very important. They are all isoelectric lines, meaning they are neither upward or downward deflection. So usually when there is any abnormality of the P wave, for instance, if it is absence, usually it represents atrial fibrillation, or sometimes in case of atrial enlargement. So usually if you, anyway, before that, let's talk about the rate and the rhythm. Usually the rate of the ECG, you usually check the rhythm first to see if it is either sinus or a sinus rhythm. So when the rhythm is sinus rhythm, usually the P wave is always followed by the QRS complex. But when it is an asinus rhythm, you realize that the P wave is not always followed by a QRS complex. So the first thing that you should do, you should check the rhythm of the ECG to confirm if it is either sinus or asinus rhythm. So if it is a sinus rhythm, you realize that after every P wave, you have a QRS complex. So then what you should do is to calculate the rates. So to calculate the rate of regular rhythm ECG, you count the big boxes between the RR intervals or the small boxes. So if you are using the big boxes, you calculate the number of large boxes between the RR interval. If there are two boxes, so you divide 300 by the number of large boxes between the RR interval. So if you have two boxes, you divide 300 by two large boxes between the RR interval, it will give you 150. So that's the rhythm, that's the rate of that ECG. But if you are using small boxes, you use 150 and divide by the small boxes. It will give you the rate of the ECG. Then after that, we've already talked about the rhythm, then the abnormalities of the waves. So we talk about the P wave. If there is absence of the P wave, it either signifies atrial fibrillation or there is an atrial enlargement. Then the PR interval, usually the PR interval is between 120 to 200 milliseconds. So if there is prolonged PR interval, it either signifies you are having a heart block, which is usually classified into three. We have the first degree, second degree. Second degree is also known as morbid. It can be either morbid 1 or 2. Then we have the third degree heart block. So in first degree, there is prolongation of the PR interval in most of them, but in the third degree, which is the one that is more severe, usually there is disjunction between the P wave and the QRS complex. So if you see the ECG, you realize that there is no any connection between the P and the QRS complex. So that's for that. So if the PR interval is shortened, that's if it is less than 80, it shows that there is either this Wolff-Parkinson-White syndrome. So prolonged is heart block. If it is shortened, Wolff-Parkinson-White. Then the QRS complex, the normal QRS complex is, I think, is 80 to 120 milliseconds. So if it is broadened, it signifies usually ventricular tachycardia. If it is shortened, supraventricular tachycardia. So you look at the QRS complex, if you realize there is short or there is widening of the complex, whereas if you're having a broad complex, it signifies ventricular tachycardia, which is an emergency. Then SVT, supraventricular, that ventricular tachycardia is an emergency. SVT, usually it depends. You either do carotid massage or you can give adenosine. And if it fails, you have to also do cardioversion. So depending on the presentation of the patient. Then the ST interval. The ST interval, we said the ST line is actually an isoelectric line. So if there is elevation of the ST, that's the ST elevation. It's usually seen in ST elevation myocardial infarction. But sometimes if there is ST depression, it also signifies an MI, or if there is any ischemia. Then the T wave, if there is the elevation of the T wave, usually is in hyperkalemia, there will be tented T wave. Then if there is depression of the T wave, it's usually seen in either MI or previous ischemia. Then for hypokalemia, usually is if there is presence of U wave, I think, right? For hypokalemia. So I think these are just few contributions before he comes back.
Thank you, Mr. Chairman. It's a great insight into ECG that you just shared. And I just spoke to the presenter. He's trying to locate from his current position to where he thinks he will have a better signal for the network. So I think for the next 10 minutes, also he will have to wait for the next 10 minutes before he made that relocation. We are so sorry about that. It's network issue. We know people have a lot of other things to do, but this is also equally important, as it will help us become better clinicians, so that we help ourselves and our patients better by improving our knowledge. So we still have some few minutes before he comes on, but he just told me that he's in fact on his way to locating, so we will await his onboarding shortly. Yes, we still profusely apologizing for these hitches. It was not foreseen. This is something you cannot anticipate. So we are sincerely apologetic to the participants, but I still want to assure you that the wait is worthwhile. We are going to learn a lot from our able, distinguished presenter, Dr. Sabiu, who is also doing everything possible within his powers to see that he delivered on this presentation. So meanwhile, I think I will add something. Yes.
If
Sorry,
he comes back, maybe we'll write on the group. I know people will I know if he comes back, people will join again. We'll write on the group that he's back.
Oh, okay, that's fantastic. That's fantastic. Yeah. Another thing that we also, like Dr. Sabiu has started taking ECG systematically, beginning from the identifying the rhythm, whether it's sinus or it's not sinus, to the rates, which Mr. Chairman has also shed light on, and then to the axis. Another thing is the axis. The axis can be normal axis, or there could also be left axis deviation or right axis deviation. So how do we crudely identify left axis or right axis?
That's the most difficult part.
Yes, but there is always an easy way. I know you are talking about, calculating the degrees using the Eindhoven triangle and so on. But another way that at primary care level, first contact, especially if you are in a busy clinic, how to identify that one is also, there's a rule of thumb there, whereby you can use your two hands. If you have seen my video, You can use your two thumbs up like this.
We can see
the left hand and the right hand. Now, the leads you are going to use are mainly lead 1, 2, and 3. So, but mainly you use lead 1 and 2. So you can call your right hand as lead 1, and then your left hand as lead 2. Now, for normal axis, if you hold your hands like this, all your thumbs are looking up. So this is normal axis. You see that the R wave, the major deflection is upward. You know, in the 3 leads, sometimes you see one of the leads has the deflection is equidistant at the QRS complex. It's neither upward deflection nor downward deflection. That's equidistant. But mainly, you see that there are predominant upward deflection in normal axis, where you have lead 1 and 2, mostly R wave showing up like this. So this is normal axis. Now, by the time you are looking at it, and then you see negative deflection on your lead 1, that is the right hand. The right thumb now is going down like this, if you can see me. So if it is going down like this, it means you have right axis deviation. You can see that it's the right hand, which you call lead 1, and this left hand you call lead 2. Now lead 1 is going down like this. You see the deflection majorly is negative, is going downward. So you know that you have right axis deviation. There are many conditions that can give that, which I'm going to talk about also. Then if you have your thumbs up like this, you are expecting this normal axis, but then you see your lead 2 going down like this. So you see lead 2 going down, and it's left hand. So you have left axis deviation. So this is crudely how, if you are in a busy clinic, how you can just look at ECG and say, oh, there is left axis deviation, or there's right axis deviation, or this is a normal axis ECG. Now, talking about conditions that can cause left axis deviation, this include inferior wall myocardial infarction, left anterior hemiblock can also give that. Other causes are artificial cardiac pacing, ventricular tachycardia with apical focus, emphysema, hyperkalemia with Parkinson-White syndrome, tricuspid atresia, ostium premium ASD, and then injection of contrast into left coronary artery. For the right axis, the causes are, it can be a normal finding in children and tall, thin adults. Okay, and then right ventricular hypertrophy from any cause, either from lung diseases, chronic lung diseases, even without pulmonary hypertension, they can cause right axis deviation. Anterolateral myocardial infarction as well can cause right axis deviation. Left posterior hemiblock, pulmonary embolus, atrial septal defects, and ventricular septal defects. Now, there are also causes of extreme right axis deviation. Okay, they are also called northwest axis deviation or no man's land deviation. The causes include emphysema as well, hyperkalemia, lead transposition. That's if you did not, or if the lead slide to some other positions that you didn't fix them well. Then artificial cardiac pacing and ventricular tachycardia. All of them can also cause right axis deviation. Then
Hello?
he's back.
Okay, is he back?
Yes, I'm back.
Yes,
Sorry.
he's back. Yes, Dr. Sabiu, you are welcome back.
Thank you very much. Sorry for the
Yes.
network issues, please.
Okay. Share the slides, please.
I had to leave that place and come to a place where there is the network, please.
Yes, I informed them about that.
Sorry.
Yes,
Sorry
share the
about
slides
that.
and continue, sir. Thank you.
Can you see my slides now? Can you see my slides?
Not yet. Not yet, sir.
Hello? Can you see
No, we
slides
cannot
now?
see them.
Okay. What about now?
Not yet. Dr. Papola, can you assist?
Yeah, he has the full right. He should be able to share from his side, just like he did earlier on. The issue is from his network over there.
Okay, thank you. Dr.
Can you see it now?
Not yet.
Dr. Papula, what's happening? I can't press on the share button. Could it be the problem of network or what's happening?
You can't see what? It's a problem of network. If you have,
okay.
If only I had the slides, I would have shared it on your behalf. Then you walk us through. I'll be navigating the slides on your behalf.
It's too heavy for it to come through email. It's like because it has many. I don't know.
Okay.
Do you have WhatsApp on the system?
What is the size of the slide?
Okay.
What's the size?
All right, let me see.
What is the size?
It's checking.
34 slides. 34 slides.
No, not the quantity. The size in megabytes.
Okay, the size. Okay, let me.
You can.
All right, properties.
Can share through Telegram.
The size is 2.9 megabyte.
That's very small. You can share via Telegram.
Telegram or WhatsApp?
Telegram.
Yes. If you have Telegram,
but I don't have it it's only in my computer, so I don't know. It's in my computer, and I can't be able to.
Do you have WhatsApp on the computer?
If I want to. Hello?
Yes. Do you have WhatsApp on the computer?
I don't have WhatsApp in the computer. On the computer.
Okay.
I don't know why it's not going. I say share. The button is not working for the share. Like it was working before. Now.
I don't know if you can proceed like that. Then later we share the slides to.
We should log out and log in.
Dr. Sabi, can you share the slides via Telegram?
He doesn't have.
I don't have Telegram.
Can you send the slide via Telegram? Okay. Then WhatsApp should do as well.
He doesn't have WhatsApp.
Login.
You can share it via WhatsApp. Dr. Husseini, he sent it to you earlier on. Have you received the slides?
No, he did not send it. He couldn't because it wasn't going through email, and I don't know, it was not on his phone, so he did not send it through WhatsApp. If you can use your Bluetooth to send it to your phone, then to send it to WhatsApp through there. Share it with your phone.
I think, Dr. Sabiu, you can exit and rejoin the meeting.
Okay.
And see if it comes up.
Exit and rejoin and see, yes. Welcome back. You can unmute yourself. Unmute yourself, Dr. Sabiu. Yes, I think it's sharing now. Yes, we can see you, and you're about to start sharing.
Can you see the slides now?
Not yet.
Can you see it now?
We can see your screen, but not the slides.
Okay. What of now?
I think you're almost there. We still your screen we are seeing.
Okay. What of now?
Well, it's a blank page.
Blank page.
Okay, back to your screen now.
I don't know what's happening.
Well, I think you're almost there. Since we can see your screen, it means the slides can also be seen.
Okay. Can you see it now?
No. Okay. Yes. It's up now.
It's out now, huh?
Yes, we can see it. Yes, it's changing.
Is it moving?
It's moving. Yes.
It's moving, right?
Yes. Go ahead. Move to the slides that we stopped.
Indication here.
But it's on the disclosure now. The slides is on disclosure.
Okay, slides is on disclosure.
Yes.
Yeah.
Yes, so it has now moved to indication.
Indication.
Yes.
So is that where I stopped?
Yes.
Is that where
I
you
think
stopped hearing me? All right.
Yes. You even finish with indication. Go to the next slide.
Okay, so I should go to the next page, right?
Yes. The next after
I didn't finish indication.
You finished.
All right. This one, procedure.
No, go down. Go
Hello?
down. Not go down after indication. The next slide.
After indication, the
You are
next
going
slide.
up. Yes.
This one.
We are finished with this one.
Hello?
Go to
I
the
finished
next.
with this one. This is the
Yes.
procedure.
So go to the next.
Hello?
After indication. Yes.
This one?
You are talking about this one before we left.
All
you
right.
have even finished with.
Thank you.
Yes, you have even started talking about the electrical activity. Yes.
All right. Okay.
In fact,
Yeah,
we have passed this one. Yes, go down. Yes, so somewhere here.
All right. Okay.
Yes.
Thanks.
So,
have I talked about this one?
no, continue from here.
All right. So as I've said earlier, the electrical activity always precedes the mechanical activity. So this one is an example of how the electrical activity happens. The depolarization of the atria will result in the P wave, which is followed by contraction of the P wave. Then the depolarization of the contraction happens at the time when there is a delay between the electrical impulses passing from the atria to the ventricles. This is represented by PR interval, PR segment. So this PR segment is the time when the ventricles, the atria contracts. Then followed by QRS complex, in which production of depolarization of the which represent the depolarization of the ventricles. As soon as it happens, then the electrical impulse will die out. This dying out of the electrical impulses during the depolarization will result in the ST segment, and this ST segment is a period in which the ventricle contracts. Then it is followed by a repolarization of the atrial electrical impulse to the resting stage, and this is represented by T wave. And after T wave, then ventricular relaxation happens. And at the time when the ventricular cells are at resting stage, that is when the the ventricles contracts, relaxes, sorry. So for the interpretation of ECG, for one to be able to interpret the ECG, who has to follow through those this format. The preamble age is very important because different age groups are interpreted differently. If you are having an ECG of a child, it's different from interpretation of ECG of an adult. So you have to know the age of the patient if you are want to have a good ECG interpretation, because children have stronger heart, so the QRS complexes are usually stronger. So you can say that an individual is having hypertrophy when the patient is not having any hypertrophy. So gender is also important, because many a times a patient may come to us in the clinic telling us that the doctor told them that her heart, the woman is, especially in women, that her ECG is having issues. But looking closely at the ECG, we will notice that it's a female, because the female have breasts, so those breasts interfere with the ECG leads. So you have a tendency, and the machine is very sensitive. If the machine that is given that interpretation is very sensitive for it to tell you that the patient is having abnormality. Meanwhile, that patient is not having any abnormality. So also when the patient is overweight or obese, there is tendency for you to say that the patient is normal. Meanwhile, the patient is having left ventricular hypertrophy because of the distance of the heart from the surface is very wide compared to a slim individual. So it's very important to note these things when you are taking the ECG. Then the calibration. Calibration is very important in every ECG, because it will help you to know whether you are dealing with standard calibration, in which when you have an amplitude of 10 millimeter per millivolt, then that amplitude is standard. I mean, the amplitude is standard calibration, as at standard calibration, or when the speed of the machine is 25 millimeter per second. So 10 millimeter per millivolt calibration, this is the calibration, and 10 millimeter per second of speed of 25 millimeter per second is the standard calibration. So if you have and the amplitude at 5 is called half calibration. But if the amplitude is at 20, you consider it as double calibration. And the situation when the technician make it at 5 is when you have this strong heart that the QRS complex are merging with one another. If they are merging with one another, the technician may say that the ECG is so bizarre, so let me reduce the amplitude from 10, which is standard, to let's say 5 millimeter per millivolt. So once he does that, you have to, during interpretation, you have to take that into cognizance. So whatever value you get for the QRS complex height, you have to multiply it by 2. So, but if you have 20 millimeter, because the leads are very tiny, so he would want to say that the waves are not so clear. Let me make it 20 millimeter so that you can be able to see clearly the waves. So if he does that, if you are interpreting it, whatever value you get for the QRS complex, you have to have it, because he's taking the ECG at double calibration. So this is also very important in ECG. So the next one is the rhythm. On the ECG, this is a typical ECG you see in most patients, and it's the most standard one. Commonly, they come with one lead that is long. If you count from here to here, because it's at 25 millimeter per second, this is the ECG paper. Every small box is represent 1 millimeter. So if you have to cover 25 millimeter, 25 of those boxes for you to attain 1 second. So if you can imagine, if you are to take for 60 seconds, how the ECG will look like. It's going to be a long ECG. So you have to look at the rhythm strip. This rhythm strip is called 10-second strip, because from here to here is calculated as 10 seconds. So this 10-second strip is considered as rhythm strip. So anytime you are checking for the rhythm, you have to check this last one. Sometimes it comes in twos. V2, lead 2, and V5 are common rhythm strips that we use in cardiology, because they help us to know better the morphology of P wave. Lead 2 tells us morphology of P wave better, while V5 tells us morphology of QRS better and T wave better. So we use, sometimes some of the ECGs will use 2 and V5. as the best ECG to, rhythm strip to use. So what is the rhythm? Rhythm. Rhythm can either be sinus or non-sinus. A sinus rhythm is a situation in which P wave comes before QRS, then T, P wave, QRS, T, P wave, QRS, T, P wave, QRS, T. So this is a rhythm strip. Once you have this pattern, P, QRS, T, P, QRS, T, is considered as sinus rhythm, so long as the morphology of P waves are uniform. You have to check the morphology of P wave and make sure that they are uniform for you to be able to say that you are dealing with the sinus rhythm. If they are not uniform, it's not considered to be a sinus rhythm. So the rhythm can be regular or irregular. If it's regular, you have to count between RR interval, this 1R, you check and compare with this one also and that one and see whether you are dealing with this similar regular RR pattern. So once you are dealing with regular RR, then this is a regular sinus rhythm, but it could be non-sinus, regular, irregular, sinus, but irregular. So the RR interval does not conform with each other. So the distance between RR interval is not equidistant in all the rhythm strip. So once you are dealing with that in the rate calculation, because you can, if you have a regular RR interval, you just take the number of RR big squares between RR interval, you divide 300 by those big squares, or you say 1,500 divided by number of small squares between the RR interval, which is better. But if it is irregular, you say you count the number of RR interval. Let's say for this one is irregular. You say 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, and say 12 by, since it's a 10-second strip, so you say by 6. 10 seconds times 6 is 60 seconds. So in a minute, you will have 12 times 6. It will give you the heart rate of the patient if it is irregular. But if it is regular, that formula, you use that formula to calculate. Then the next thing is for you to be able to calculate the axis. So the axis is what is giving people a lot of problem. So you can see that this is a typical ECG pattern. Sometimes if you have difficulty, always check this thing, this tracing. And you see the first value is the heart rate. So you need not to calculate, bother yourself at calculating this, whatever. You can just look at this one and say that, okay, for this patient, the heart rate is about 119 beats per minute. The pulse rate is, PR interval is this, QRS complex is this duration, QT interval duration is this, QTC is this. So you can use this one to not to bother yourself, because in practice, you don't have time to be calculating those things. So it's better you look at the typical ECG ECG to be able to calculate the rhythm, to look at the rhythm, whether it's regular sinus or irregular sinus or non-sinus rhythm. So the next thing is the QRS axis, which is difficult, is the thing that is making people to get scared about the ECG, but it's not something difficult. It means the orientation of the heart in the chest wall. If you look at it, you say QRS complex axis. What brings about the QRS is the polarization of the ventricles. So you can see that the ventricles here, look at the ventricles of this heart, is located within the normal, this green shaded area. So from minus 30 to plus 90 is what we consider is considered normal, meaning that these, the whole vector, the vector, the magnitude and direction of the impulse coming from the sinoatrial node is directed toward the apex at these angles. So anything that is above this is right axis deviation. Anything that is beyond 90 plus 90 is left axis deviation above minus 130 degrees, or plus 90 above plus 90 is right axis deviation. And extreme axis is when you are not sure whether this left axis is so extreme that it goes here, or this right axis is so extreme that it goes here. So we call it extreme axis. So it's or indeterminate axis. So the importance of this axis is for you to know what is the etiology of the heart of the abnormality. If it's left axis deviation, you have to think about things that will cause left ventricles from hypertrophy, like hypertension, like aortic stenosis, like aortic stenosis, like even coarctation of the aorta, systemic hypertension, as the case might be. So will result in left axis deviation. So also when you have MI, myocardial infarction, causing weakness of this part of the heart can cause left axis deviation. But if you have things that would cause hypertrophy of the ventricles, will result in right axis deviation, or any condition that may cause or like MI that involves the right ventricles will cause the weakness of the right ventricle, thereby leading to right axis deviation. So this is and you have to remember these standard leads. Lead 1 between the leads that check the electrical activity between AVL to AVR is called lead 1, which is the bipolar lead, and between AVR to hello.
Yes, we can hear you now, but yes, we can hear you now, but you were off.
You were talking about bipolar leads. You were talking about bipolar lead.
Thank you. So bipolar leads are lead 1, 2, and lead 3. They are leads that check the electrical activities between two leads, and that's why they are called bipolar leads. And they are not represented on the ECG that we see. The ECG that we see, the leads that we apply on the patients are called augmented leads. But this lead 1, lead 2, lead 3, they are formed by the like a program in the machine. It's the machine that that does this activity of identifying those leads. Okay, so that is that about leads. So when we get to how do we calculate the leads, the axis in the on the ECG? Calculating the axis sometimes is there are two ways to calculate it, or more than two ways to calculate it. There's rule of thumb, which may be important in this lecture because it's very easy to understand. If you use your left hand as lead 1, look at this lead 1, look at the deflection. Deflection is upright, and this deflection is upright because the heart, the vector or the magnitude and direction of the impulse is directed toward the apex, toward the apex of the heart. That is why it's positive. If it's directed away from the origin, that is the sinoatrial node, it will look negative. Like look at this AVR, is negative because if you look at this image, the AVR, the synod node is located here. So this AVR, this is the AVR, is always away from the AVR. So it means that always AVR, for it to be normal, it has to be negative. If it is positive, then there is abnormality. So also V1, this is the location of V1, assuming that this is the sternum. Can you say this is the location of V1? So V1 sometimes, and look at the ventricles, because the QRS is produced by the ventricles, and SA node is located here. So if you have always, what do you call it? QRS complex in V1 are also negative because look at the lead location V1 and look at the QRS complexes. So they are away from the origin or the direction of flow of current. So that is why in lead 1 and AVR.
Can anyone hear him?
No, he's off.
Hello? Hello?
He's back. Yes,
hello?
Continue.
We can hear you now.
I hear you.
Yes, so that's why always AVR and V1 are always negative. Because if you look at these leads, look at this is the origin of where the sinoatrial node generation of current, and is going towards the apex. So always AVR, which is here, and V1, which is here, are always negative on ECG. Once you see it as positive, it's considered to be abnormal. So axis is knowing, it's trying to tell us whether the heart is situated in a normal position in the chest wall. So like this one, lead 1 is upright, AVR is negative, and AVF is always upright, meaning that if lead 1 is upright and AVF is upright, so it's a normal axis. But when you have in lead 1, the the QRS complex is negative, and the
We can't hear him again.
Hello.
Yes, so you are back.
Yes. Okay. For lead 1 and AVF, lead 1 is upright, AVF is also upright, so it's a normal axis. But if lead 1 is negative and AVF, which is on the right hand side, is positive, it means that you are dealing with right axis deviation. If lead 1 is upright and lead AVF is looking is downward, which is on the right side, the one that is upright, which is on the left side, is lead 1, meaning that is a left axis deviation. So once you see upright in lead 1 and you see downward in lead AVF, it's called left axis deviation. When you see left lead 1 going downward, lead AVF is upright, it's called right axis deviation. So what about the P wave? All the waves, what we do for the waves, you just look at the height of the waves and the width of the wave. Like if the width is like 2.5 small squares for lead 2, from here to here is about 2.5 small boxes or small boxes. So the height also is the same, also around the same thing. The height is also about 2.5 small squares.
So it's categorizing.
Are you seeing?
Hello?
Hello?
The same way.
Yes, we are seeing. We are with you.
All right.
Dr. Popular, mute your mic.
All right.
I'll ask you.
So if you have upright P wave, hello?
We are with you. Continue.
Okay. If you have an upright P wave, the height of the P wave is 2.5 small square. The width of is 2.5 small square is considered normal P wave. But if the height is more than 2.5 small square, the height is called right axis deviation. If the width is more than 2.5 small square, it's called left axis deviation. If you have both the height and the width are more than 2.5 small squares, it's considered biatrial enlargement, which is biatrial enlargement. So like for this, in this ECG, if you look at it,
yes. I hardly have a good network.
If you look at it here, the height is not more than 2 small squares.
Doctor,
it's not more than 2 small squares.
Popular is like your mic is not muted.
I'm trying to.
You can't be able to say that this patient is having a right axis deviation, but in actual sense, if you look at V1 here, that's why interpreting the P wave, you have to look at lead 2 and V1. Hello? You have to look at lead 2 and V1. Lead 2, V1 will always, sometimes lead 2 may make you have normal height and normal width, but the V1 will show deepening. That is what you call Morris index. P terminal force from here, beginning of the QRS complex to the downward is more than 1 small square. And this is considered as left axis deviation. So always when you are checking like this one, can you see from here to here is more than 1 small square, is considered left axis deviation. So if you have the height, the beginning of this one, the P wave in V1 is the one that is taller. So it's considered right axis deviation. Assuming that this one, it goes up like this before going down, it's called right axis deviation. But if you have even the height and the deepening also more than 1 up, more than 1 down, is considered biatrial enlargement, like in this one, up and down more than 1 small square. If you draw an isoelectric line, a line like this that will pass across, is considered biatrial enlargement. Okay. So like in this one, can you see this? This ECG is showing up, and the down one is almost 1 small square. So this is called right axis deviation. Right axis deviation. Right atrial enlargement, sorry, right atrial enlargement. So what about the QRS complex? Also in the QRS complex, you consider height and width. The QRS height commonly, width is commonly less than 110 milliseconds. That is 2.5 small square. So you have rule of 2.5 small square. P is 2.5 small square. PR interval 2.5 small square. Even QRS complex is 2.5 small square. So you have to remember that because it's a rule for you to remember that. So it has to be less than that. Anything more than that is considered wide complex. And wide complex QRS complex is seen in bundle branch block and electrical dissociation. And what is that bundle branch block? Meaning that the heart, after the AV node, there is Purkinje His fibers. Purkinje His fibers divide into anterior and posterior fasciculus, and those fascicles can get blocked due to either myocardial infarction, either any chemical intoxication, and many other things that may cause blockage in the conduction of the electrical activity. So this will result in bundled branch block or complete inability of the electrical current to pass from the atria to the ventricles, which is called electrical dissociation. So what about the height? The height will help us to know whether we are dealing with hypertrophy or low voltages. Low voltages is a situation in which the height of the QRS complex is small. It's considered small, like in limblets, if it is less than 5 millimeter, like this height, assuming this is the ECG, the height of the QRS in the limblets here is less than 5 millimeter, and the height of this is less than 10 millimeter. So any V1, V2, V2 less than 10 millimeter is considered low voltages, or limblets, the QRS complex less than 5 millimeter is considered low voltages. So low voltages are seen in obesity. So you have to ask whether you have to see in your ECG whether the BMI of the patient is high, about 40. Then you can say that that patient is a normal patient, probably is due to obesity. Or if the patient is having emphysema, because the distance between the heart and the surface is wide. So emphysema also gives low voltages. DCM, dilated cardiomyopathy, because the heart is weak, it gives low voltages. RCM, restrictive cardiomyopathy, is a situation in which the muscles of the heart has been infiltrated by certain chemicals. It's called. It also leads to low voltages. Or whether if the patient has pericardial effusion, is considered. Hello.
Yes, Dr.
If the patient is having. Yes.
Yeah. So can you put it on the slideshow, so that we can be seeing these ECG pictures? It's going to be
You're not seeing them.
More bold. We are seeing,
like
but we want it in a slide share. Check.
Hello.
That
slide share.
At the bottom of your slide
share. Like this
at the
one,
bottom of the slide. Yes.
Okay.
That's how much it can expand.
Is it okay now?
It's still the way it is. We want it to full the screen so that the screen will be full.
Yeah, from my side, it's on slide share, but at your own side, it's not on slide share. I don't know what's happening.
Dr. Popola, can you help us guide him on how to make?
Is it okay now?
It's still the way it is, because we want.
Maybe we can continue. Dr. Saini, you can zoom the screen. You'll appreciate it.
Okay, but are you seeing my pointer?
We are seeing it.
We are seeing it.
Are you seeing my pointer?
Yes.
Move it, let's see. I saw it the other time when you moved.
I'm not seeing it now.
You can see now?
Yes.
Are you seeing the pointer?
It has disappeared again.
Yes, we can see it now.
Back.
You can see now?
Yes, it's on the slides. Yes.
Are you see the pointer now?
Yes.
You can see the pointer.
Yes, just
Yes, we can see the
continue if you
pointer.
cannot make it. Continue.
All right.
Thank
So
you.
if you have low voltages are seen when you have obesity, emphysema, DCM, right? Restrictive cardiomyopathy, a situation in which chemicals have infiltrated the muscles of the heart. If you have fluid accumulating in the pericardium, pericardial effusion or pneumothorax, all this can give low voltages because the distance between the surface and the heart, the surface where the ECG, the leads are attached, and the heart where the electrical activities are happening is wide. So, but if you have a slim individual, some children, because they have a slim chest wall and thin individual, or whether the patient is having LVH, hypertrophic cardiomyopathy, you have high voltages. And these high voltages are considered hypertrophy. Hypertrophy of the LVH is calculated using voltage criteria. When you have S in lead 1, R in V5 or V6 more than 35, it's called LVH. There are many criteria for knowing LVH, but this is the simplest formula. And then, so also if you have dominant R in V1, it's considered RVH, right ventricular hypertrophy. Or when the R over S ratio in V1 and V2 are greater than 1, it's considered right, especially in the presence of right axis deviation, is considered right ventricular hypertrophy. Like for in this case, okay, the R in V, you can take the R in, okay, this one, okay, like this one. If you take the R, okay, have issues. All right, this one, if you check the R in V5, V1, or S in V1 or V2, for this one, V2, the S is longer in V2, so it should be the one that you should use. If you can count, because it's very tiny, it's very, it's like about 1, 2, 3, 4, 5, 6, 7. It's like about 7 times 25 is like even 35 millimeters. So you take R also in V6. Look at V6 or V5, whichever is longer. Like in this one, in V6 is longer. There are about how many big squares? 1, 2, 3, 4, 5. 5 big squares, meaning 25. So 25 plus 35 is like 70 or 60, 60 millimeters. So this is left ventricular hypertrophy. Left ventricular hypertrophy. This is an example of low voltages. You can see in limb leads is less than 5 small squares. In chest leads is also less than 10 millimeter. So it's like low voltages. So this is an example of low voltage and high voltage. So this is an example of right axis deviation. I mean right bundle branch block. If you have dominant R in V1 and that is forming what appears to be like M shape and like what appears to be like W shape in V6 with widening of QRS complex. Look at the QRS complex in this one. If you can see the grid lines, it's like widened more than 3 small squares. From here to here is more than 3 squares. So this is considered a bundle branch block. Because widened QRS duration. So since there's widened QRS duration, so you are dealing with either bundle branch block or electrical dissociation. So, but if it has this pattern, M shape in V1 and W shape in V6, this is called Monroe pattern. Like M, you start with M, you end with W, Monroe. And there's R within the Monroe, and it's considered right axis deviation. And so also, if you can have William, look at this one, it appears like M. And this, you can consider it V or W, or if you have typical, this one, it could be either V or N shape. So long as the duration of the QRS complex is more than 3 small squares, it's considered bundle branch block. So this is a pattern that is looking at, it's like close to William, and that L within the William is left bundle branch block. This will help you to know whether the patient is having left bundle branch block. And these kind of patients are the ones that always come to you with palpitations, and they always come to you with some copal attack, and They may come also with chest discomfort. They are usually in heart failure, and those are the kind of patients that may require an intervention. So what about T-wave? T-wave is always upright in all except AVR and V1, just like QRS complex. Okay, they are all upright except in AVR and V1, which they are negative. They are downward. They are looking downward. So they are usually typically less than 5 millimeter in the limb leads, in the precordial leads, and 10 millimeter in men, and 8 millimeter in women. So the height, if the height is tall, it can be seen in hyperkalemia and or acute MI. In acute MI, there is what we call hyperacute T wave. You can, if you see the tall, the P wave, look at it, is very tall, like this one, is considered as hyperacute T wave, or you are dealing with hyperkalemia. So it's usually symmetrically inverted in ischemic heart disease, neurogenic, like if the patient is having stroke, they are usually inverted. So once you see T wave that are inverted, symmetrically inverted, like in this one, look at it, it's symmetrically inverted. You are either dealing with ischemic heart disease, or you are dealing with stroke, or you are dealing with HOCM. Or further, if you see the height of the QRS complex are very high, are very tall, then you could be dealing with the hypertrophic cardiomyopathy. But if it is the height are not tall, and there is no associated ST segment elevation or depression, so you may be dealing with neurogenic T wave. And in neurogenic T wave is always diffuse. All through, you will see V1, V2, V3, every lead is showing T wave inversion. Every lead is showing T wave inversion, and this is seen in neurogenic T wave, like in stroke, especially hemorrhagic stroke. Ischemic heart disease, yes, they are usually they are inverted, and usually they come with T wave inversion, or elevation, ST segment elevation or depression. I mean, so it could be flat in certain situations like hypokalemia and ischemic heart disease. It can be flat. So further investigation will help you to know what you are dealing with. What about if it's camel hump, meaning that it's biphasic? Look at it. When it has, I don't have it here. Yeah, look at it here. One T wave and another bump again, like a camel hump. So you are dealing with either heart block, or you are dealing with severe hypokalemia. If it is biphasic, like in here, look at it, is biphasic, you are either dealing with hypokalemia, whether you are dealing with hyperkalemia. If there is a presence of U wave, especially if there is presence of U wave, you can also be dealing with ischemic heart disease. So what about the PR interval? PR interval is the beginning of P and the beginning of the QRS complex. What do I mean by that? So the beginning of P and the beginning here, beginning of P and the beginning of QRS complex, this is what you consider PR interval. So it's normally, if it is 3.3 to 5 centimeters, 3.5 seconds, small squares, small squares is considered to be normal. But if it is more than 5 small squares, you are either dealing with AV block, heart block. If it's shorter than this 3, you are dealing with pre-excitation, or you are dealing with AV junctional rhythm. What about the QT interval? And this PR interval will help us to know whether you are dealing with electrolyte abnormalities or you are dealing with AV block. What about QT interval? QT interval is the beginning of the QRS complex and the end of T, from the beginning of the QRS complex to the end of T here. Once you have that, is more than, the normal is between 350 and 450. If it is more than 450, 440 is usually considered prolonged. If it's less than 350, is narrow. So short QR complex is considered is seen in hypercalcemia, congenital short QT syndrome. Digoxin effect also can give short QT interval. You can have long QT if you are dealing with hypokalemia. All these hypo electrolytes that are hypo, temperature also low, reversal of after resuscitation, if you have reversal of return of circulation after post-cardiac arrest, it's also given long QT interval. Raised intracranial pressure also gives that. Congenital, if you have long QT syndrome, can also give that. Certain drugs commonly give QT interval. And this prolonged QT interval is very important if you are dealing with it. So typically, if you have in ECG, if you have difficulty, always look at the ECG here, look at the interpretation, look at the QT interval. Here for this patient, it's like about 400 and I think is 59. So it's like prolonged, 459 of 69. It's like prolonged. Sorry about that small, poor ECG quality. So if you are dealing with this prolonged QT interval, once the patient is having prolonged QT interval and you give him drugs that will cause further prolongation of the QT interval, that patient is at risk of sudden cardiac death. So you need to be looking at this QT interval when interpreting the ECG. And you can see that ECG is very important. The role of ECG in the management of patient is very important, especially patient with even for drug monitoring. What about the segment? ST segment, when the ST segment, the QRS complexes is the beginning of the end of the QRS complex and the beginning of T wave. Sorry, from the end of PR segment. Sorry, PR segment is here. End of P and the beginning of QRS complex is seen depressed in acute pericarditis, and it's also elevated in ischemic heart disease, and it could also be depressed, especially if you are looking at the AVR. It could be depressed in ischemic heart disease. So, but in acute pericarditis, it's usually diffuse. All through, you will see ST segment depression. So you can see if you draw a line here, you can see that this line is going down. I don't, as if I have an image for that. All right, I think I misplaced the image. There's image for that. So what about ST segment elevation? ST segment elevation, always look at the J point. Look at the J point here is the end of S. The end of S. S, you have Q, this is R, S pattern. So at the time when the S finishes and the beginning of the ST segment, this is, and you draw a line from the TP line, there's T here before the P, you draw a line to go down, this is called ST segment depression. So it's up sloping ST segment depression, and this could be normal in certain individual. But if it were down sloping, it's looking down. Okay, if it's down sloping, it's caused it's an abnormality. So, but if also you draw a line and you see ST segment elevation here, but you see a J point here. J point is seen in certain situations, like if the patient is having hypotension, hypothermia, sorry. If the patient is having hypothermia, can have presence of J wave, or if the patient is having hypokalemia, can also have a J point. So this J point is very important in interpreting the ECG. Elevation is seen in acute myocardial infarction, premenstrual angina, pericarditis. In pericarditis, it's always diffuse and is usually saddle shaped. Like in this one, it's like saddle shaped. This is the type that you see in pericarditis. It's like camel hump. So Brugada syndrome also, you can see elevation. Raised intracranial pressure, you can see ST elevation in all those conditions. So if you have difficulty sharing the ECG with an expert, there are certain criteria we use to know whether we are dealing with true elevation of MI or all those conditions. What about depression? Also can be seen in ischemic heart disease and also as a reciprocal changes in acute myocardial infarction. And what do you mean by reciprocal changes? Can you see on this ECG, the ST segment is elevated here, but the leads that are looking at this anterior word are the inferior leads. Can you see the inferior leads is also showing ST segment depression? So this is called reciprocal changes because this ST segment elevation is seen in the anterior leads, and the anterior leads are V1, V2, and V3. They are the anterior leads. There is some elevation on it. And the leads that are looking at opposite to those leads are lead 1, 2, and AVF. These ones are called the inferior leads. So they can be able to know whether you are having, this is called reciprocal changes. So this MI is a true MI because there is reciprocal changes that we see in the inferior leads when the ST segment is elevated in the anterior leads. Can you see this one also? There is ST segment in the inferior leads, and there is ST segment depression in the anterior leads also. This is also a true MI. So this is called mirror image of the QRS complex. So ECG can be seen in emergency situation, like in MI. Once you have an MI, it's an emergency situation. So you can see that role of ECG is very important in determining cardiac emergencies. Once you have this one, patient with this abnormality, ST segment elevation, so it's an emergency, you need to act urgently and try to salvage the process, the patient. So also in a certain situation like AV dissociation, can you see that P waves, look at the rhythm strip here. Okay, all of them are ever rhythm strip, they are 10-second strip. You can see P wave here. This is another P wave. There is no pattern. There is another P wave that is buried here. P wave here, one here, here. So, and look at the RR interval. If you look at the RR interval here, you can see that this patient is having bradycardia. So even bradycardia, this is what you call complete heart block. And commonly, this kind of patients are the patients that will come to you in an emergency. They will come with the syncopal attack, loss of consciousness. They may also be having breathlessness, as the case might be. So you need to act fast and be able to see that, to do an ECG. An ECG will show you that we are dealing with AV dissociation, and this kind of patients are the patients that may warrant pacemaker insertion. You can also have supraventricular tachycardia and ventricular tachycardias. These are seen, they are also emergencies. They are the part of the ECG abnormalities that may make the patient to present to the hospital with breathlessness, chest pain, syncopal attack. And once you do an ECG, it gives you this type of ECG, then you can go ahead and manage the patient. So also these are a form of ventricular tachycardia. So ECG is very important in emergency situations. And once you are able to check those abnormalities that I mentioned, then you should call the attention of either a specialist, call the cardiologist to confirm what you've seen and for the patient to get proper management. ECG also is important in patient monitoring, especially in high dependency unit and intensive care unit, because to help you to know whether the patient is deteriorating or the patient is improving in ICU or in high dependency unit. So also during anesthesia is also important in detecting cardiac abnormalities during surgery. It can also help you in after cardiopulmonary resuscitation to see whether you have achieved a good response, whether you can to take the patient to be at ease that the patient has regained full. Otherwise, this will help you in assessing that. So there are certain situations in which you will do an ECG, and the patient may come with symptoms, palpitations, or syncopal attack, or whatever all problems that you have, what have you, breathlessness, features of heart failure, and you do an ECG, the ECG is normal. You can also do whatever test, you repeat the ECG again, you think there is a heart problem, and the ECG is normal. And in this kind of situation, there are certain tests that will help you, ECGs that will help you to know whether you are dealing with arrhythmias or you are dealing with some coronary artery disease like unstable angina. In unstable angina, commonly there is an abnormality, but there are certain situations in which if you don't place the lead properly, it may appear to be normal. In this situation, you will subject the patient to treadmill ECG, what we call stress ECG, in which the patient will be on a treadmill as he's exercising. His ECG is being captured on a screen, and to see what is the effect of the heart or what is the response of the heart as the patient is exercising, and that could reveal whether the patient is having coronary artery disease or other, or it may provoke the arrhythmia that the patient would have, especially during exertion. So the importance of stress ECG is in the diagnosis of coronary artery disease, and this coronary artery disease is a situation in which the coronary arteries are not completely blocked like in MI, but there is some fluid blood that is flowing to the heart, and that could give rise to intermittent angina, and the patient may come with the intermittent angina. So it's also, if you don't subject the patient to stress ECG, you can't be able to diagnose that. Most of the patients' ECG here with coronary arteries will appear normal. So subjecting those patients to ECG is very important, especially if they persistently tell you that they are having symptoms, especially during exertion. So recognizing exercise-induced arrhythmia or ischemia also, ECG is helping that. In exercise prescription, there are certain situations, if the patient develops MI, you have to prescribe the exercise for him. If the patient is having also other forms of cardiac abnormalities like arrhythmias, you have to prescribe exercise for that patient. And you do, and ECG is helpful, stress ECG is helpful in trying to identify whether the patients are at risk of having VTAC, arrhythmias, or are at risk of having myocardial infarction if they exercise. Pre-employment risk assessment, like if you want to tell the patient that he's fit to do other jobs that are high-risk job like piloting, you have to subject those patients to stress ECG. Otherwise, you will be embarrassed and tell the employers that the patient is normal, and meanwhile the patient might not be is not normal. Optimizing patient for treatment and discharge after MI and for invasive treatment. So you can agree with me with these few slides that I mentioned, that ECG is we need an ECG in our facilities, because ECG is very simple to acquire, it's very valuable because it can detect many other conditions in the heart, and it's relatively inexpensive to buy, because if you consider how it was, you can't buy life, because no matter the amount of money you have, if you don't take good care of your heart, there's going to be an issue. And it's easily reproducible. If you teach a technician, many technicians, and you give them training, and after the training, you do what we call reproducibility testing. You tell them to check the ECG. One person does the ECG, and another one also do the procedure. You compare the ECG and see whether they've gained what you taught them or otherwise. So it's easy that you can, if NMA can help in organizing, coordinating and advocacy to all the MDs in Jigawa State and policymakers in the state on the importance of making the ECG available in all general hospitals. That will be a good way, a very important role in early diagnosis and management of cardiovascular disease. So there is also need for NMA to also set up a WhatsApp platform involving cardiologists and advise colleagues to key into those platforms, and the cardiologist will help in coordinating, or if there is any difficult ECG, the cardiologist can be able to give a guide as to whether the patient should require is an emergency or otherwise. So in conclusion, ECG is a procedure that detects electrical activity of the heart in the form of graphs, and it can help to diagnose many abnormalities of the heart and its surrounding structures. Its role in the diagnosis of treatment of cardiovascular disease can never be overemphasized. You can agree with me that provision of ECG, with this lecture, that provision of ECG in all general hospitals in the state will be a wake-up call for this year's World Heart Day that says that use your heart for action. So if our leaders or policymakers make sure that ECG is made available, they have given an action to make sure that the heart of our teeming populations are salvaged. Thank you very much.
Thank you very much, Dr. Sabiu. Like we said, we know that he is going to do justice to this important topic. We thank you and we appreciate your effort. Despite all the hitches of the network, he was able to change from one location to the other just to be able to deliver this lecture as promised. And he has delivered it very well. And we thank you for this effort. Now, I think the recommendations you made would have been noted, especially by the SOC. And I think one of the recommendations which I like very much is the one that you suggested that a WhatsApp should be formed wherever, whenever we have ECG in our general hospital done, and there is one confusion or the other, it can be shared on the platform so that experts can give their inputs, which will help a long way in managing the patient in question. Thank you very much.
Thank you very much.
I think, yes, we should open the floor for questions and comments, suggestions, and inquiries from the participants. So if you have questions, you can either unmute yourself and ask question, or you can put it in the comment section. We can read it out for the presenter. Thank you very much.
Umar Saleh, you can talk.
Okay. Hello, Dr. Umar Saleh, go ahead.
Yes, good morning, sir. Thank you very much for the presentation, and we are happy that NMA was able to organize this important meeting. So my questions are, number one, with regards to the axis, this abnormality. So you mentioned that there is left axis deviation, right axis deviation, and extreme axis. Yes. So this extreme axis, I didn't hear anything about it, or maybe some network issues interfered with when you are talking about it. So I want some highlights about it. Then secondly, there is this issue. I heard you mention something like P-terminal force and the atrial enlargement, the ECG appearance with regards to those ones. So thank you very much.
Okay, thank you very much, Dr. Umar. With regards to the extreme axis, I said sometimes in hypertension, you can have severe hypertension, especially eccentric hypertension, or hypertension that always comes with maybe heart failure. That hypertension may result in left axis deviation that is so extreme that can go to, that the axis may lie between -90 and -150, maybe between -90 to maybe, let's say, 180. It could be possible, you know. So this cause of hypertension is considered extreme, because if you are able to calculate the axis, all right, and calculating the axis is in situation in which if you have QRS that is negative in V1 and QRS that is also negative in AVF, this is considered as extreme axis deviation. So if you have a hypertensive patient, you subject him to ECG and he has a lead1, negative QRS complex in lead1, and he has also negative QRS complex in AVF, that patient is having extreme axis deviation. So if the cause of the heart failure or the cause of the hypertension is showing that the hypertension is so extreme, is the kind of patient that you say, just go for echo, or you can go for anything can happen. You understand? Because the heart is so extreme that it has given an extreme or indeterminate axis. Are we together? Have I communicated to you now?
Yes, sir.
Yes, regarding extreme axis. So also if the patient is having pulmonary hypertension, and pulmonary hypertension, you know, can give rise to right axis deviation, meaning that it will give hypertrophy of the right ventricle. So if the hypertrophy of the right ventricle is so severe enough that it may lie within this plus 180 to this axis. This right axis is so extreme that it will lie here. So that individual is having pulmonary hypertension that is so severe enough to cause maybe heart pulmonary or heart failure. I hope you are getting. So that's why this extreme axis deviation, there is you can't check a book and see what is the cause of extreme axis deviation. There is no cause for that. It's only that the right axis deviation is so extreme that it may make the axis to lie within that. Like if you have a patient who come to you with right axis deviation on ECG, okay, with right axis deviation on ECG. And how will you know that there is right axis deviation? Is when you calculate the axis. So for in that case, you have to do this hexaaxial referencing system. Hexaaxial referencing system is a situation in which you will check the leads that is more isoelectric, like this one. The positive and negative will cancel one another, is the isoelectric lead. So you check which one lead is perpendicular to it. Like this lead is AVL, is perpendicular to lead 2. Lead 2 is upright. So the axis is located exactly at 60. So it means that you are dealing with a normal axis. Look at this one. Okay, which one is more isoelectric? Probably this one, and probably this one. So this one is a little bit difficult because you can't be able, if you calculate minus this with this one, could be almost similar to minus this with that one. But look at R wave in AVR here. This dominant R in AVR is showing you that the patient is having right axis, right ventricular hypertrophy. If you also have chest leads also, you check V1 and you see dominant R in V1, it means that that patient is having right ventricular hypertrophy. So once there is right ventricular hypertrophy, and you look at the ECG, this is negative, and this is negative also, it's completely negative. It means that you are dealing with extreme axis deviation, but with right ventricular hypertrophy. So that kind of patient is having extreme right axis deviation. Am I communicating, Umar?
Yes, sir.
Hello? Yes, so the patient, because he's having hypertrophy, right ventricular hypertrophy, and you can't have right ventricular hypertrophy, and you have an ECG that is negative here and is negative here. It's supposed to be that if you are to calculate, you will calculate the axis to lie between 90 to 180 plus 180. But if you calculated it and you saw that it's between 80 to 90 to 180, but you have negative here and predominantly negative here. There's no positive at all here. So meaning that you are dealing with right axis deviation that is so extreme. So it's an extreme axis deviation in that individual, but from right ventricular problem. Are we together? But if you have like a left atrial enlargement, you have left ventricular hypertrophy, and you have negative here, and you have negative here also. You see it's an extreme axis deviation, and you have hypertrophy. That patient is having extreme left axis deviation. Are we together? So you have to look at the causes for why of that left axis deviation, which is the hypertension. Probably is the hypertension that is so severe to give rise to that left axis deviation, and it's a poor prognosis in that individual. Am I making sense?
Yes.
Okay, so the P-terminal force is a situation in which, like, if you look at this from the beginning top here of this, you see from the beginning, it goes up like this. This is, and it comes down. So if it goes up like this here, if you look at lead 2 also, it's only up, there's no down. So this kind of patient is only right axis deviation, because the left limb of the, which is signifying the right ventricular chamber, is upright, is looking up. so it's called right axis deviation. But if from the beginning, the top of summit of this to the down, the nadir of this wave from summit, this is called P-terminal force. From here up to this here down is more than 1 millimeter, is considered left axis deviation. From the summit here to the bottom here, if there is more than 1 small square, it's called a left axis deviation. Is it okay? Left ventricular,
Yes.
left atrial enlargement, sorry. From here, summit here to the nadir here or down here is more than 1 small square, is considered left atrial enlargement. Look at it here. From here, summit here to the nadir down here is more than 1 small square, is considered left atrial enlargement. But here, since there is up more than 1 small square and down more than 1 small square, is considered biatrial enlargement. Are we together?
Yes, sir.
All right.
All right.
Any more questions?
Thank you.
Thank you. Any more questions? Dr. Omar, you can put your hand down if you don't have another question.
Sir, I'm sorry. You
Yes.
mentioned also about can the breast tissue cause the voltage to be
Yes.
low?
No, breast tissue always cause this ECG, like here. Let me show you an ECG here. The breast tissue lies around here. So if the breast tissue in a woman, it will be causing undulation of those QRS complexes. You will be showing undulation. So the ECG machine will consider that undulation as, because if she's breathing, the leads are going up and down. So it will be causing undulation on those either here, here, or here. I hope you get either here or here or here. So the ECG will interpret it as a problem. So they will tell you that the patient is having MI, anterior MI. And commonly, it's showing you that the patient is having anterior MI. It's either here, here, or here. So it's commonly showing you, see whether the patient is having anterior MI. I hope you get. Sometimes the undulation may appear here also, depending on the location of the location of the leads that you put, and whether the breast is pendulous or not. If so pendulous enough that is causing that undulation in all the limb leads, all the chest leads, it may make the machine to assume as if there is an abnormality. Meanwhile, there is no any abnormality in that individual. Is it making sense? So it's due to the interpretation. Always ECG in woman will interpret the ECG as an abnormal. Don't always consider it abnormal, especially in women. Always consider that artifacts, those artifacts, they are called artifacts, are considered abnormality, and the machine may pick them as an abnormality and will interpret it as such. Hello?
Thank you.
Yes, we can hear you. Okay, thank you, Dr. Sabiu, Dr. Umar. Any other question?
No, sir.
Yes. All right,
Okay.
go ahead.
Go ahead.
Okay, sir, you mentioned about unstable angina, and you said that there could be some changes on the ECG. So I was a bit yeah, because the knowledge I have is usually in unstable, you'll be having the pain at rest and on injection. And if you do the ECG and the cardiac enzymes, they'll all be normal. So I don't know if you can elaborate.
So I think it's a slip of tongue. I wanted to say stable angina. Stable angina may come with the normal ECG. I think it's a slip of tongue. They may come with a normal ECG, but if you subject that individual to a stress test, it may show an abnormality. Okay? I think it's a mistake, but in stable angina, yes. Stable angina.
That's what you said. That's what you said. So usually, if you subject them to stress ECG, it usually shows changes.
Yes, it will show changes. Yes, it may show changes.
Okay, what changes?
But if it's stable angina,
is
already
it
you
the
have
ST
the chest.
elevation or what?
Hello.
Yes, we can hear you.
Yes. Sir, were you talking about stable or unstable angina? Because I was a bit.
No, I was.
Is it the unstable angina that?
Unstable angina, you don't subject them to exercise. They already have the chest pain. But stable angina, they don't have any symptoms, but when you subject them to exercise, they can have that.
Okay, I understand. Thank you.
Yes. Yes.
Any more question?
So my battery is low. We don't have light
Okay,
here.
so
Okay. Yes.
next,
It will go off now. Yes.
yes, question.
Hello. Yes.
Hello? Yes, I
We
can
can
hear
hear
you.
Can I? Okay. So thank you very much for this wonderful presentation. Because ECG has been one of the headaches of a lot of clinicians in all the, particularly for us in secondary health facilities. So I want to also make recommendation with what you started on.
Yes.
I am suggesting maybe if we can have like a specialty networks which shall connect our first contact clinicians in these secondary health facilities, and then so that they can be communicating with people like you. For instance, we have a cardiology network. Probably maybe you have a single person, a medical officer per general hospital, so that we can be communicating, can open the WhatsApp group or a communicating channel, so that.
Yes. Hello? Hello?
It's like we lost him.
Hello?
Hello? Hello? Can
Yes,
you hear
hello?
me?
Yeah, we can hear
Yes,
you
can
now.
you hear me now? Yes, I think if you can
Yes,
have, so that hello?
Go ahead.
Yes, we
go
can hear
ahead.
you.
Hello? So if you can have such network, it will surely improve the management of our patient. And as you said, thank God we have people like you, particularly at the top, and we have gone through you during our house job, and we know how supportive you are, and still now we still contact you. But you can have a broader network like that, either through WhatsApp. And then also my question is, although it may be out of context, if you may know the estimate cost of an ECG machine. I think this shall help the Nigerian Medical Association to collaborate with the hospitals. And then also if you can suggest any partner NGO or cardiology organization that we can liaise with to provide such machines, because I know currently not many general hospitals do have such kind of ECG machines. Thank you so much.
Okay, thank you very much for the
Thank you very much, Dr. Shamsu, for the contribution and question. So with regards to the ECG network, yes, I will want the NMA to tell us the names of the heads of all those secondary facilities, because let me at this juncture let me commend Dr. Mahmoud. Dr. Mahmoud, former MD of Ringim General Hospital. He has done a lot in providing an ECG in that facility, and the ECG is a very good ECG. I don't know how he came about that ECG, but he was able to get an ECG, buy an ECG, and also contact us and we came and gave lectures to all the staff in the hospital, the relevant staff in the hospital, and they immensely appreciate our support in giving them lectures on ECG, and they have known the importance of ECG, and we've been collaborating since that time on the ECG platform. So truly, if you can get their names and phone numbers, we can, even from our own side here, form the network expert or network ECG network group, so that if anybody has a difficult ECG, he can forward it in the platform so that we can have a discussion on that. And we've already started with Dr. Mahmoud. That would lead me to the second question, the cost of the machine. I'm sure if you can call Dr. Mahmoud, the MD of the machine is okay and is cheap. most of the machine now, they are very expensive. They are like around like 1 million and above. But I'm sure his own, he told me that is around, I don't know, because I don't know whether he bought it before this current economic issue. But I'm sure it won't be more than 500,000. And I'm sure those facilities can afford this very important investigative tool in their own facility. 500,000 naira is not an expensive thing, considering how considering the burden of cardiovascular disease in Nigeria. So I think NGOs, yes, we are communicating with some NGOs, and I wanted to also pay a courtesy visit to the WHO in Jigawa State and the primary healthcare agency in Jigawa State, in trying to see how they can be able to support those secondary centers in providing them with those ECG facilities and other basic cardiovascular facilities in the state. So primary healthcare agency and WHO would have would pay a courtesy visit to them, have familiarization visit, and tell them the importance of this ECG, and hopefully they may key in Jigawa State. They may.
Comrade,
hello.
Yes,
Hello?
sir.
Please mute your mic if you are not having the flow, please. Some people are causing interference.
Hello.
Okay. Thank
Yes.
you, Dr.
So
Sabiu.
NGOs also, yeah, I think here in the forum we have a lot of people that are in contact with the NGOs. Probably they may help us in seeing how those key NGOs can help in providing ECGs to the secondary facilities in Jigawa State.
Okay, thank you.
I hope I've answered your question.
Yes, I think you did. And one important thing is that NMA, I'm sure, is going to take up this challenge and see how they can lead the way for this collaboration with the cardiologists and then the NGOs, and see how this thing can be provided, the ECG machine can be provided in the facilities for obvious reasons, because it's a very valuable tool that should be there. Some general hospital may have it. I think like Kazora General Hospital, there was a time I was there, I was asking for ECG. They told me that there was one ECG that was donated to them, but they used it once or twice, and then they just put it in the store and no longer use it again because of lack of availability of I think manpower, and then the interpretation issue. But this is a very good platform where those kind of machines can be put to use, and then we also learn, because you have to constantly keep, trying to learn, and that is when you will learn. Especially ECG, it needs persistence, because when you say you are going to read everything and then understand it at once, it's not like that. It's not easy like that. You have to keep using it and keep utilizing it for you to be able to be conversant with the
so
how to use it.
Okay.
Yes.
So with regards to this Kazaure, I think if we can be able to organize training, I think we can give a training regarding how to use the to do the procedure, and to help them to know how to have basic ECG interpretation in the facility.
Okay.
Yes.
So I think NMA should
yes,
liaise with all the general hospitals. Those that have the machine can key in and have a training, even if it is virtual training, for those that have the machine already in the store that they are not using. While those that don't have, then they should try to acquire it either through the collaboration with NMA and the cardiologists and then the NGOs, or through some other means. If they can fund it and buy it directly, they can do so as well, because of its importance. Let's move to the next question, which is, I think Dr. Noura Basirka is raising
Dr. Basirka has been raising his hand.
Yes, Dr. Noura, you have the floor. You can ask your question. Are you with us, Dr. Nura? Yes, he raised his hand since.
Unmute your mic.
Yes, unmute yourself and talk. Dr. Shams, your hand is still up. Do you have another question? Okay, Dr. Nura is not with us likely.
I don't have any question.
Oh, okay.
My question has been
okay.
answered.
Okay, thank you very much. So, Mr. Chairman, I think Dr. Sabiu.
Please, can we have the slide at the end of the presentation also?
Yes, the slides will
yes,
be.
I will
It's
try
so
and send it.
concise. Yes, it's so concise that you can always get back to and check one or two things.
Okay, I will
Mr.
try and
Chairman,
send it, inshallah.
You can, Mr. Chairman, you have the floor now to make some remarks.
All right. Thank you very much, CME committee under the leadership of Dr. Hussein Magaji for organizing such a wonderful event for us. And thank you very much, Dr. Sabiu Hamza, for sparing time out of your busy schedule to come and deliver such an important lecture to all of us. Undoubtedly, this is going to make impact and is going to improve the amount of care we give to our patients. One of the roles of NMA is to organize continuous educational development for doctors. And it is in line with this that we thought of organizing this. And we wish to have